All right. Okay. Now we go to the second lecture, Adrenal Gland Pathology. Okay. This lecture, as compared to the first lecture, I think is quite challenging for me and for you. Okay. It's quite difficult. It's not quite complicated. But I try my best to make it simple. Okay. The rest you need to read by yourself. So at the end of this lecture, every one of you should be able to at least to understand the causes and the clinical cause of adrenal hypofunction and neoplasm. Have to understand the pathogenesis of various types of Cushing syndrome. Describe the gross and microscopic changes of adrenocortical hyperplasia, adenoma, and carcinoma. Kalau we look at the learning objective, it's not that much actually. We try to make it simple. All right. First, we go to the anatomy of the adrenal glands. Adrenal glands is another special organ of the pituitary just now. Okay, it is a pair organs. We have a both a right and left adrenal glands that lying on the top of the kidney. Very nice, located on the top of the kidney, and it is enclosed within the capsule. It has a capsules, and the cortex have the three zone. We call it zona glomerulosa, fasciculata, and reticularis, and after that it has a medulla. So mainly it composed of two area, cortex and medulla. But the important one is the adrenal cortex. Okay. This is the cross section of the adrenal. Here the capsule is the cortex with the three layers, and then the medulla. The zona glomerulosa, the zona fasciculata is the broadest zone with the 75% of the cortex is the zona fasciculata. And then we have zona reticularis. After that is the medulla. Okay. Okay. This is the microscopy, the morphology of the cortex. You can see here, this is a fibrous capsule. The fibrous capsule here, and then follow just beneath the capsule, we have the zona glomerulosa that produce the aldosterone. And then we have the zona fasciculata that produce the cortisol. And we have the zona reticularis that produce the androgen. And then after that, we have medulla that composed of the chromaffin cells. Okay, it depends on you on how to remember this, but this is the most common way how to remember this. It starts from the first, the outer part is a salt, a sugar, and sex. Okay, and you know the aldosterone related with the salt, and then sugar. Cortisol is actually a sugar, and the sex is related with the sex hormone here. Okay. Basically, these are the things that we need to cover for today. Within 1 hour, we need to cover about the adrenocortical hyperfunction, the hypofunction, and neoplasm. The most important one is in the hyperfunction because we have 3 zones just now. And the hyperfunction, we need to discuss the hyperfunction that involving the first zone that related with the aldosterone, the second zone that related with the cortisol, and the third zone that related with the sex hormone, okay, and androgen. And then after that, we will go one by one about the hypofunction and also the neoplasm. Okay, I hope everyone clear about what we are going to cover during this lecture. Okay, first we start with the hyperaldosteronism. And we have the primary hyperaldosteronism and the secondary hyperaldosteronism. Primary hyperaldosteronism is when there is a the aldosterone produced directly from the adrenal gland, meaning that there is an adenoma this is the most common cause when there is an adenoma of the adrenal cortex, and the adenoma is related with the area that producing the aldosterone, which is the zona glomerulosa. Okay, so because that area is affected much, so it producing mainly the aldosterone. In this condition, we call it Cushing syndrome. When there is adenoma of the adrenal cortex that producing mainly aldosterone, we call it Cushing syndrome. So 80% of the primary hyperaldosteronism is due to the Cushing syndrome. Cushing syndrome is a solitary aldosterone secreting adrenocortical adenoma. All right, and then we may have the source of the aldosterone from another source, like the cortical hyperplasia, which is uncommon, and like granulosa cell. Hybrid granulosa cell responsive to ACTH, which is also uncommon. Okay, and what happened when there is increase in the aldosterone? We know that aldosterone is something that their function is to retain the salt, the sodium. Okay, just now we have ADH. ADH is something that very prone to retain the water, but aldosterone, they like to retain the sodium. So what happened? What happened in the renal tubules? There will be sodium reabsorption from the tubular urine back into the bloodstream, and then the potassium will be moved from bloodstream into the tubule and will be excreted. So the patient will present with the hypertension due to hypernatremia and also hypokalemia. All right. So hyperaldosteronism, as I told you, we have primary and secondary. So primary is due to the production of the aldosterone by the adrenal cortical adenoma. Okay. So in this case, when there is a overproduction of the aldosterone, what happens when there is a overproduction of the aldosterone? There will be inhibit the RAS to decrease the plasma renin level. Okay, so the body found that there is a lot of aldosterone in the body, so will suppress the renin at the kidney. Okay, no more renin produced because the body already achieved their sodium level. All right, but in condition in secondary hyperaldosteronism is any condition that when the kidney perceive that the body volume is low. Okay, there is a low in the intravascular volume, so the kidney will produce the renin from the juxtaglomerular apparatus, GGA. So why they produce the renin? Because intra-body volume low, the intravascular body volume low, so body has to produce a lot of renin to activate the RAS system, the renin-angiotensin system. So the renin-angiotensin system will convert the angiotensinogen to angiotensin 1 and then convert into angiotensin 2. This one will stimulate the aldosterone production. So the body increase in the aldosterone due to this, not directly from the adrenal cortex. So this is, we call it hyperaldosteronism, secondary hyperaldosteronism. So how to differentiate whether primary or secondary? So we look at the renin level. In this case, the renin will be high. So aldosterone increase because the high renin increase in the activation of the renin-angiotensin system. Okay, understand? So the clinical manifestation of the hyperaldosteronism The primary hyperaldosteronism include the thirst, excessive thirst or polydipsia, increase in urination or polyuria, hypokalemia, hypernatremia, the muscle weakness or fatigue due to hypokalemia, and as well as hypertension. Hypertension is a hallmark features due to the sodium retention. Okay. The secondary hyperaldosteronism causes all these things. Whenever there is meaning that all these things that cause the body perceive that there is low intravascular volume. For example, when there is a decreased renal perfusion, arterial hypovolemia, like in congestive heart failure, cirrhotic liver, or in fact in the pregnancy. The estrogen will induce the plasma renin substrate. So in this case, the body will produce a high renin that cause further increase in the level of the aldosterone. We call it secondary hyperaldosteronism. All right. Okay. So Settle had Cushing syndrome or hyperaldosteronism. Now we go to the hypercortisolism. Okay, remember Cushing syndrome just now when there is a primary hyperaldosteronism. Untuk secondary, kita tak panggil Cushing syndrome. Alright? Okay. Now we go to the hypercortisolism or Cushing syndrome. Okay? Cushing syndrome is a complex hormonal condition that caused by elevated glucocorticoid level or cortisol due to exogenous administration. The most common, meaning that daripada luar. Kita dapat cortisol tu daripada luar. The most common type, especially those who taking the steroid. Okay, and then endogenous administration, like primary hypothalamic pituitary disease, like pituitary tadi yang produce ACTH, okay, which is 70 to 80% is due to pituitary problem, and then hypersecretion of cortisol due to the adrenal adenoma or carcinoma or hyperplasia. Okay, and then due to ectopic ACTH, like in the paraneoplastic syndrome. Okay. This photograph, I think, is very helpful. Although you can see here, it's like an old picture, but it's very useful. The most common is Cushing syndrome is due to the exogenous medicine that containing steroids. So we call it iatrogenic Cushing syndrome. Iatrogenic means that whatever condition that related with the medication given to the patient, right? And then the rest all endogenous and start from the primary hypothalamic pituitary disease, the most common one due to pituitary adenoma, and then whether cortisol due to the adrenal adenoma that producing a cortisol, okay? Maybe it's related with the zona fasciculata, okay? Tadi adrenal adenoma producing aldosterone, but now adrenal adenoma producing cortisols because they have 3 layers, right? 3 zones. Okay, or maybe increase in the cortisol due to the endogenous or ectopic ACTH from the paraneoplastic syndrome. For example, patient with a lung cancer, all right, that producing a lot of ACTH that stimulate the adrenal gland. The adrenal gland become hyperplastic and produce a lot of cortisol. All right, this is you need to understand this picture. Okay. In clinical scenario, to make it practical, whenever patient present or suspect for Cushing syndrome, they divide into 2, whether exogenous or endogenous. To know whether exogenous or endogenous, very simple. If patient never take any medication, not on any steroid medication, so that's not exogenous. It must be endogenous. So if endogenous, we need to differentiate whether this cortisol Cushing is ACTH dependent or ACTH independent. Means that we need to know the ACTH level, whether high or low. Okay. For ACTH dependent, the ACTH level is very high. So we can suspect that it must be due to the pituitary adenoma, because pituitary adenoma is the one who produce the ACTH, and increase in the ACTH produced by pituitary adenoma will act on the adrenal gland that causing increase in production of the cortisol. All right, or maybe ectopic ACTH from the lung, for example, or maybe ectopic CRH from the hypothalamus produce the CRH, and then corticotrophin releasing hormone from the hypothalamus that stimulate the anterior pituitary to produce ACTH. Okay, that's under ACTH dependent. Okay, and then for the ACTH independent, meaning that there is increase of the cortisol, but ACTH not increase, meaning that it's not related with the ACTH. It's not coming from the pituitary, it's not due to ectopic ACTH, but cortisol is increased due to the local causes. For example, adrenal gland tumor. So the adrenal cortical tumor, or when patients have McCune-Albright syndrome, or in this condition whereby this is a primary hyperplasia of the adrenal gland. All right, but it's not that common. But this is in clinical, they divide into this because they want to know where is the causes, where probably the causes. So so easier for them to treat the disease when we know where is the origin. Okay. Now we go one by one. The Cushing syndrome, that the due to pituitary causes, which is the most common of the endogenous Cushing syndrome, 70 to 80%. So of course, the most common is due to corticotroph adenoma. Okay, corticotroph adenoma, ACTH producing microadenoma. So the female, of course, pituitary means the female higher than male. Okay, and it is young female, 20s to 30s. Okay, it causes bilateral diffuse or nodular adrenocortical hyperplasia. You know why? Because when there is increase in the ACTH by the pituitary glands, so of course the ACTH will stimulate both adrenal, not only one adrenal. Okay, so that's why it's causing the bilateral diffuse hyperplasia of the adrenal glands. Not only one area hyperplastic, but the whole gland will be hyperplastic because the hormone stimulate the whole area, not only single area. Okay. And then there is increase in the serum cortisol, of course lah, by the adrenal glands. And then also increase in the ACTH. Okay. And this is considered as ACTH dependent Cushing syndrome. Okay. But for the adrenal Cushing syndrome is when there is a Cushing syndrome due to the primary adrenal neoplasm like adenoma or carcinoma or hyperplasia of the adrenal glands. Okay, it is ACTH independence, not related with the ACTH. And usually when we check the blood, we take out the blood, look at for the cortisol. Of course, the cortisol increase, but ACTH low. So we can suspect for the adrenal Cushing syndrome. Okay. All right. Oh, ada animation lah pula. Okay. Okay. Paraneoplastic Cushing syndrome. It is account for most of the remaining cases lah, about less than 10% actually. Yeah, this one is common in men. You know why? Because this paraneoplastic Cushing syndrome is mainly from the lung cancer. Lung cancer is most common in men. ACTH dependent Cushing syndrome, of course lah, because of ACTH producing that causing the Cushing syndrome, produced by the small cell carcinoma of the lung, the carcinoid tumors, the medullary carcinoma. My brother, my brother just died a few days ago due to the lung cancer. Lung cancer. Okay, no one in my family got cancer actually. basically we can conclude that we are not genetically cancer family. But you know, this is a sporadic when because of our lifestyle. Okay, so I just want to tell everyone here, yeah, especially for men and all of you, please advise anyone in your family, chronic smoker, please stop smoking. I think that the main influencer for the lung cancer is due to the smoking. Although you have no genetic in your family is a cancer, but that smoke, that cigarette able to change that can cause mutation to your genes. All right. Iatrogenic Cushing Syndrome. Iatrogenic Cushing Syndrome. For those who are on medication, when you take the steroid from outside, of course, that is considered as the cortisol, that further will cause the reduction in the suppression of the ACTH, will because a low in ACTH that cause the atrophy of the adrenal glands. Okay, but except for the zona glomerulosa lah, because zona glomerulosa is not influenced by the ACTH, not dependent of the ACTH, but the two zone that depends on the ACTH, it is the fasciculata and reticularis. Okay. As a gene, that's why those who are on steroid, for example, patient with nephrotic syndrome or any immune disease like SLE, they need to take the steroid. But you know, they whenever they cannot stop the drug suddenly, they need to taper down the dose, because it's very dangerous. Need the body to adapt with that slowly and slowly. So the clinical cause of hypercortisolism, as I told you just now, you need to know by your fingertips. What is this? So you know that this is a buffalo hump. So this is the moon face. And then the skin, the striae, the hirsutism, patient, the most common presentation, hypertension, the weight gain, the central fat deposition in the form of truncal obesity, moon faces, and buffalo hump, decreased muscle mass, and proximal limb weakness. All this you need to know, and please find the pathophysiology of each sign and symptoms. And then how we diagnose the Cushing syndrome? Usually we need to do the 24-hour urine cortisol level to see the level of the cortisol. Of course, there will be loss of the normal diurnal pattern of the cortisol secretion. And another test we need to do is the dexamethasone suppression test. This is important because, sometimes when we check for the serum ACTH, we cannot differentiate whether if it is high, we cannot differentiate whether it is a pituitary or atopic. But when we do the dexamethasone suppression test, only we know that it is actually pituitary Cushing syndrome when it is suppressed of when we proceed with the dexamethasone suppression test, with high dose it is suppressed. Okay. So this basically the summary. What happened in terms of cortisol and ACTH level. Of course, in pituitary adenoma, both will be high, and there will be bilateral hyperplasia of the adrenal glands. The same thing in the ectopic ACTH, but for the primary adrenal adenoma, for example, there will be increase in the cortisol, but of course, ACTH will be reduced because negative feedback by the cortisol. And then there will be unilateral atrophy. One adrenal will be producing a tumor producing a lot of cortisol. Another one will be atrophy. The same thing with the exogenous cortisol. Of course, there will be increase the cortisol level in the body, but ACTH will be low. When there will be because negative feedback to the pituitary gland to reduce in ACTH, suppress the ACTH. When ACTH is suppressed, there will be bilateral atrophy of both adrenal, right? Okay. So now settle hyperaldosteronism. Now we go to the adrenogenital syndrome. Okay, it is actually the disorder of the sexual differentiation, such as patient may have a virilization if toward the male, or feminization if towards the female. It caused by a primary adrenal disease or gonadal disorder. The adrenal cortex secretes two compounds. In adrenal cortex, it secretes two compounds of the steroid, actually, the sex hormone, dihydroepiandrosterone that produced in the zona reticularis, and as well as androstenedione that converted to testosterone at the peripheral tissue. All of this under influence of the ACTH. So the excess secretion can be a pure syndrome, or sometimes it can be due to Cushing syndrome, because because this zone also been affected by the ACTH. So in the most common excessive in terms of androgen, the sex hormone, the most common cause is the CAH lah, congenital adrenal hyperplasia. Congenital adrenal hyperplasia. It is autosomal recessive. It is autosomal recessive, inherited metabolic error characterized by the deficiency of this enzyme. Actually, many other enzymes that related with this disease, but the most common one is 21-hydroxylase deficiency that involved in dia punya cortical steroid punya pathway. Particularly yang related adalah, yang involved adalah cortisol lah. The steroid synthesis is then channeled because of the deficiency of this enzyme. So the steroid synthesis tadi akan channel kepada another pathway that causing the increase in the androgen production or virilization that cause the features toward the androgenital syndrome features lah in CAH. So the cortisol deficiency stimulate the ACTH secretion with a resultant adrenal hyperplasia. We need to see this in order to understand whatever I have mentioned just now. Okay. 90% of cases of the congenital adrenal hyperplasia is due to the deficiency of this enzyme. 21-hydroxylase enzyme. Okay. This here and it is here. Okay. So the severity of the disease in CAH depends on whether the total loss of this enzyme, or it's just a less than total, or just a mild loss of this enzyme. For example, if it is a total lack of this enzyme, of course, everything will be channeled here. Everything will be channeled here. So there will be increase in the sex hormone, the testosterone, everything, and it's toward the causing the virilization, everything. Okay. So when we talk about the androgenitalism, we have a few types, whether we call it salt wasting, or without salt wasting, or non-classic. This one, for you to for your own readings, for you to understand. But whatever, it related with the severity of the enzyme lacking, whether total lack or less than total, a very mild defect of this enzyme. You can see here, if it is total lack of this enzyme, there will be no synthesis of the mineralocorticoid at all. Tak ada langsung yang apa ni? ACTH deficient in cortisol to stimulate more ACTH. So what happened? Semuanya channel toward here. So there will be no ACTH. There will be no aldosterone, no cortisol here, but the things all become channeled to this here, to this. Okay, that cause the hyponatremia, hyperkalemia, virilization, cardiovascular collapse, and can possible causing death. Okay, this is for your reading, because in this condition, it is actually the life-threatening condition. But in our case, mainly presented with, these are patients present with ambiguous genitalia. meaning that if this is less than total, less than half, what we call less than total, not total, but at least they still can have some ACTH, although it is lacking. So patient presented with there is signs of masculinization in females to oligomenorrhea or hirsutism. Depends whether male or female. And usually patient presented with ambiguous genitalia. That one you need to read further on the CAH, okay? And then we go to the adrenocortical hypofunction. When we talk about hypofunction, meaning that there is a deficient or insufficiency of the adrenocortical hormones. So it's whether primary or secondary. In acute or in primary but acute, we call it adrenal crisis. But in primary but chronic, we call it Addison syndrome. So this topic, actually, you need a lot of further reading after this. What does it mean with the adrenal crisis? What is Addison syndrome? We have many syndromes to cover here. Cushing syndrome and Cone syndromes, congenital adrenal hyperplasia, and now Addison syndrome, adrenal crisis, many things here. Okay, I just try to simplify it for you, but you need to read by your own. Okay, this adrenal crisis is actually the primary acute adrenal insufficiency, where it can cause a sudden increased demand for steroid that precipitated by any form of stress that require immediate increase in the steroid output from the glands in patients with chronic adrenocortical insufficiency. For example, in rapid withdrawal of the steroid in patients that maintain exogenous steroid, as I told you just now, a patient on steroid, on high dose of steroid, but suddenly stop. So that can cause the adrenal crisis, very dangerous. Please advise the patient need to taper down of the dose. And in case of the adrenal hemorrhage, we call it the adrenal hemorrhage, and also in case of the Waterhouse-Friderichsen syndrome, this is the hemorrhage to the adrenal as well in the IVC. This can cause an adrenal crisis. And for the chronic condition of the primary adrenal insufficiency, we call it Addison disease. This is very uncommon, but of course in medicine we need to know, including the uncommon disease, that resulting from the progressive destruction of the adrenal cortex, mainly hypofunction or the insufficiency is due to the destruction, whether acute destruction or the chronic destruction. Generally, the clinical manifestation include actually what they want to tell here, because it is a chronic condition, the clinical manifestation do not appear until the condition, the adrenal cortex, compromise almost 90%. Okay, 90% only they cause the problem. For example, in the autoimmune adrenalitis, the AIDS patient, the metastatic cancers, almost 90% compromise only they have the symptoms. Okay, clinical manifestation. The clinical manifestation, the Addison disease, their clinical manifestation include here hyponatremia, hypotension, hyperpigmentation due to increased ACTH, hyperkalemia, hypoglycemia. You can just imagine this picture. This picture with a lady with a bronze color skin. This is due to the hyperpigmentation, change in the distribution of the body hair, weakness, very weakness. This is young but looks like old people, or like hypoglycemic, very thin, weight loss, weakness, dehydration, everything. These are the clinical manifestation of the chronic insufficiency of the adrenal glands. And then we have the secondary and tertiary adrenocortical insufficiency here. Secondary or tertiary, it depends whether it's from hypothalamic pituitary causes or withdrawal of the suppressors called glucocorticoid therapy. So, so any disorder of the hypothalamus, pituitary axis, or like a metastatic cancer, infections, all can cause the secondary, we call it secondary adrenocortical insufficiency. But there will be no hypopigmentation in the secondary, only in primary cause the hypopigmentation or bronze skin just now. Well, you know why? Because hypopigmentation is lacking because melanotropic hormone levels are low. Okay. Okay, now we go to the adrenocortical neoplasm. Okay, neoplasm, whether neoplasm of the cortex or the medulla. And we should cover hyperplasia, adenoma, and carcinoma. Again, I want to tell you here, we usually, although you have hyperplasia, carcinoma, adenoma here, but we usually test you on the most common one, which is adenoma. Okay, but at least you need to differentiate. When we call it adenoma, when we call it hyperplasia. For example, by looking at this image here, here, this is a normal, not this one normal. This is a normal, and the size which is shrinkage like this, we call it atrophy. But the one with increase in the size as compared to normal, we call it hyperplasia. Okay, hyperplasia. Okay. Adrenal hyperplasia is actually you need to know this one, but it is uncommon. The adrenal hyperplasia, especially for the primary, kalau secondary hyperplasia, adrenal hyperplasia tu common lah because of the ACTH stimulation. Okay, but for the primary adrenal hyperplasia, it's very uncommon. Okay, for example, this one lah, massive macronodular adrenocortical disease, primary pigmented nodular adrenal disease. This is a primary hyperplasia, which is uncommon. This is a example of the adrenocortical nodular hyperplasia. In this disease, you can see here macronodular adrenocortical disease. This is primary pigmented nodular hyperplasia. Actually, their gross picture will be hyperplastic, increase in the size of the adrenal glands, and it is forming a nodule like this. So, adrenocortical nodular hyperplasia. Okay, this is an example of the adrenocortical tumor or adenoma. We can see here very nice, well circumscribed tumor. Yeah, just within the arising from one of the arising from the cortex. Here the cortex, the yellow one, and is continue forming a mass here. Okay, so this tumor arising from the cortex of the adrenal glands here. And here in the middle, it is medulla. Okay, this is medulla. Okay, so it's forming appears very solid tumor, homogeneous surface like this, well circumscribed, well encapsulated here, bright yellow in color. All right, so that is actually adrenocortical adenoma. Okay, when it is functional, it is associated with Cushing syndrome or hyperaldosteronism. Okay, whether means functional, if it is functional, meaning that producing hormone. Okay, so it's usually associated with the cortisol and the aldosterone. Okay, not other the sex hormone is very rare. And then the typical one is well circumscribed like this, very well circumscribed nodular lesion. Can give the size, the diameter. You can see the tumor here is expanding the gland, become increase in the size of the glands. And on the cut section, the cut surface here, you can see, you can describe about the color. It's a yellow in color, yellow to brown in color due to lipid content within the tumor cells. The cells within the zona, within the cortex is most of the cells contain lipid. That's why when it's proliferate, forming a neoplasm or tumor like this, it tends to give the yellow in color. Okay, and most are clinically silent. Most are clinically silent. Silent here means that non-functioning. All right. Okay. And then look at the microscopy. The morphology of the cells from the adrenocortical adenoma. If you found this picture, you should be able to assume that this is from the adrenal, because the cells are very typical for the adrenal gland in the sense that the cell you can see here have very distinct cell outlines. You can see clearly the cytoplasmic border, and it forming a very nice nest or cluster like this. So clustering like this, and the cell you can see here, the cells are very homogeneous. The cell are uniform, rounded, uniform. Tak ada sangat variasi, uniform. Okay, macam pakai uniform lah, uniform school uniform. Okay, and then the cytoplasm, you can see it's clear, right? Clear, and some of it become vacuoles, and it contain a lipid droplet actually within the cytoplasm. All right, and inside the nucleus just very small nuclei. Sometimes it's not that big, it's small, and it don't have no nucleoli inside. This is a very benign tumor. Okay, and but for the carcinoma, it may have carcinoma, but it's but very rare lah, quite rare. And if it is carcinoma, it's more likely to be functional. And functional meaning that it associated with increase in the production of the hormone. And usually patient associated with the virilism. When it is related with the apa tu testosterone hormone semua tu. Okay, mostly large and invasive lah, exceeding 20 centimeter in size. Alright, when it is carcinoma, of course the cell become very bizarre looking, prominent nucleoli inside here. Okay, this is nucleoli, very prominent, very pleomorphic. Pleomorphic meaning dia ada besar, ada kecil, dia punya nucleus not uniform anymore. Alright, okay. But to say again, in all the endocrine tumor, to say it is carcinoma, we must give evidence of the invasion and the metastasis by right, not by the morphology or histology. Okay, so the pathology of adrenomedulla, finish about the cortex. Now we go to medulla. The pathology of the adrenomedulla. It's not much. You just remember a few tumors, especially pheochromocytoma. Okay, pheochromocytoma is actually the tumor that arising from the medulla. But we can also have the neuroblastoma, especially for the kids. Okay, and then of course you need to know a little bit about the multiple endocrine neoplasm or MEN. All right. So for the pheochromocytoma, the tumor uncommon neoplasm that arising from the medulla. Okay. Pheochromocytoma, this is the way how to remember. P means parent, so you know that this is adult tumor. It's never happened in the children. And the name here, pheochromocytoma. Chromo means chromaffin. It's arising from the chromaffin cells. That's why this tumor producing epinephrine and norepinephrine. So that's why patients who have this tumor presented with the hypertension. This is the only correctable hypertension and present in the young men, especially when we remove the tumor, suddenly there is no more hypertension. All right, this is the good hypertension when we can correct the hypertension by removing the tumor. Okay, So whenever we talk about a few chromocytoma, you should know when there is a start with P, so there will be 5 P's for the chromocytoma with to describe the few chromocytoma. It is pain, pressure, palpitation, perspiration, and pallor. But I don't think you should remember all these. You just think of the sympathetic over the expression because it related with the adrenaline and no adrenaline. So it give you sympathetic punya expression. Okay, in those with few chromocytoma, the clinical features are related with the sympathetic. And the most important clinical features is the hypertension. And in few chromocytoma, since the conventional school, old school always talk about the rule of 10. A rule of 10, meaning that 10% malignant, 10% bilateral, 10% extraadrenal, 10% involving kids, and 10% familial. Okay, but nowadays, many research done, there's no more rule of 10. It can go into 10 to 25% of malignant nowadays, okay? And it is associated with MEN 2A and also MEN 2B and also run in the family, okay? These tumors, yes, as I mentioned, it is the only correctable hypertension, okay? This is an example of the gross finding of the tumor. You can see the hemorrhagic. This is the mass that arising from the medulla, okay? And morphologically, you can see here the cells are arranged in, we call it a solid nest like this, or we call it Zell-Bollen pattern. The Zell-Bollen pattern means that there is a small nest, just like the alveolar of the lung, like that. And the stroma of the cells is, actually reached by the blood vessel. You can see all RBCs there. Okay, this is the microscopy of the few chromosoma, which is I don't think your level to know about this, but the clinical features you need to know. And then for the neuroblastoma is the tumor that from the medulla that usually happen in the kids. It is the most common extracranial solid tumor of childhood. Okay, most common during the first 5 years of life. The site mainly the most common is abdomen. So the children usually presented with the abdominal mass. When we palpate, there is a tumor, and actually the tumor is arising from the adrenal glands and become very big. Okay. Whenever we use the blast here in the name of the tumor, meaning that it is a immature cells. The tumor contain immature cells. When there is tumor contain immature cells, just think of kids. Most of the time, it happen in the kids. So the tumor that start with the presence of word blast, usually the tumor that involving the kids. Okay. This is an example of the neuroblastoma of the adrenal medulla that causing the, we call it here dwarfing of the kidney, meaning that the kidney become kecil sahaja and the tumor become very big and large like this, okay? The tumor become very big with the necrosis, cystic changes and hemorrhage, okay? You get very heterogeneous areas of the tumor, no, okay? And the tumor can be very big, more than 1 kilograms. Okay. And under microscopy, it just like a brain tumor, forming a rosette, a lot of rosette formation here, the rosette formation here. Whenever we have the cell like this, that surrounding the empty space, like this, that sometimes contain only the fibers inside here, we call it rosette formation. And usually the cells are very primitive, very bluish like this, very primitive, not well differentiated like squamous ke columnar ke whatever, but it's a very primitive cell like this. This is a blast cells, okay? I think that's all from me for this lecture. I just want to introduce that I have produced 3 books so far by ebook, Actually, this book is meant for my Master of Pathology Part 1, the Year 1 Master of Pathology. But I think this book, a lot of picture with their salient features, salient points, labeling, everything, the most common exam cases for them. But actually, I think it's also benefit to undergraduate students, especially for the how to score in theory exam. I think this is the tips on how to score in theory exam. Everything I put here, how to score, how to cater the MTF, the SBQ, the OSCE. No, OSCE not theory. This is theory, okay? And for those who have read the note before the lecture, congratulations to you, but I'm sorry that I just circulate via WhatsApp. By right, I should put in the e-learning. I will put the e-learning after the lecture. You know, in terms of to be a good, you need to read before the lecture once, and then you go through before the lecture, and then you listen for the lecture. By the time you listen for the lecture, you need to jot down everything that you have made a note at your lecture notes, whatever, to strengthen your understanding. But then after that, what should you do? No need to read the lecture notes anymore. After that, because you have read twice, before the lecture and during the lecture. And after the lecture, what should you do? Anyone volunteer? Ada yang sedar lagi tak? Okay. After that, what you should do? You read
Jawab soalan.
Jawab soalan. Or try to jawab soalan. Okay. Okay. Before that, sebelum nak jawab soalan tu, you all ada textbook tak? What is your textbook? Robin. Okay. This is the time for you to read Robbins. You know, Robbins is very lengthy. Kalau you read before you go into lecture, you akan ngantuk, you tidur, you tak faham, makin confused. Okay. Now, when you read before the lecture, you read lecture note before lecture, and then you read second time the lecture note during the lecture. Okay. And then after the lecture, you read textbook. Go get your Robin, turn the endocrine, ambil endocrine topic, cari pituitary, cari adrenal, baca from beginning sampai habis. At that time, bila you baca, you dah boleh absorb, you tak ngantuk, you jadi interesting. Sebab you dah faham, dah banyak benda yang you faham, dah cover masa lecture. Masa tu lah you baca, kena to strengthen your knowledge, to make it consolidate pun your knowledge. You need to baca thoroughly your textbook now. Okay? So now go back and read. Before that, we try to answer this question. Okay, satu sajalah, letih dah rasa. Okay, adrenocortical adenoma is bilateral in most cases.
False.
Yeah. False. Why? Siapa cakap tu?
Because it is unilateral. So dia punya
unilateral. Bila? Okay. Bukan bilateral ya? Bukan bilateral. Yang selalu bilateral ni bukan adenoma, tapi adalah hyperplasia. Hyperplasia dia bilateral because ACTH dia akan stimulate both sides. Is majority encountered as incidental findings? Siapa yang ada ni? Okay, jawab. Is majority encountered as incidental findings?
True.
Wow, siapa tu?
Kabilan doctor, because it's most of that are clinically silent, so mostly it will be found as incidental findings.
Yes, good. Incidental. Susah nak. Kalau kita, yes, mostly silent. Mostly silent. Mostly it's not producing any hormone or whatever. And you know that the adrenal gland is so small, so small. Although it is a tumor there, it's not, when you palpate the abdomen, it's not nothing. It's commonly its majority are incidental findings. All right. And causes Cushing syndrome when associated with hypercortisolism.
True.
Confused ni. Siapa ni?
Cushing syndrome.
Cushing syndrome ni.
Yeah.
Cushing syndrome, remember the solitary tumor of the adrenal that producing the aldosterone. Okay. Kalau hypercortisolism ni Cushing syndrome. Okay. Saja nak bagi confuse lah tu. Okay. Is associated with Martman syndrome. Ada tak associated man syndrome?
False.
Huh?
False. False.
Tak ada kan? Adrenocortical adenoma tak ada. Yeah. Okay, it's composed of cell with intracytoplasmic lipid content.
True.
Alright. Okay, I think that's all from me. Any other question?